Hello, today I'm going to talk about uninterrupted Dabigatran versus Warfarin for ablation in atrial fibrillation. First, I'm going to talk about the definition. Atrial fibrillation, AF or AFib, is an abnormal heart rhythm characterized by rapid and irregular beating of the atria. It often starts as brief periods of abnormal beating, which become longer and possibly constant over time. Often episodes have no symptoms. Occasionally there may be heart palpitations, fainting, lightheadedness, shortness of breath, or chest pain. The disease is associated with an increased risk of heart failure, dementia, and stroke. It is a type of supraventricular tachycardia.
A healthy heart works continuously to pump blood around the body by beating regularly under the control of electrical impulses that originate from the sinoatrial or SA node, the heart's natural pacemaker. These impulses radiate from the top to the bottom of the heart in a coordinated way. Each heartbeat consists of two stages where blood enters the atria, which subsequently contract, and forces blood into the ventricles. These in turn also contract, forcing blood out of the heart into the pulmonary and systemic circulations. In atrial fibrillation, electrical impulses do not originate in the sinoatrial or SA node, but from a different part of the atrium, or in the nearby pulmonary veins. These abnormal electrical signals become rapid and disorganized, radiating through the atrial walls in an uncoordinated manner. This can cause the walls of the atria to fibrillate or quiver rapidly rather than contracting normally. Electrical signals are transmitted irregularly from the atria to the ventricles, which both fail to contract in a synchronized way. During atrial fibrillation, because the atria do not contract regularly, blood does not empty efficiently into the ventricles and begins to pool in the atria, especially in the atrial appendages. This pooling of blood can cause clots to form, which, if dislodged, can travel in the bloodstream towards the brain. The clot, or embolus, can potentially obstruct narrow blood vessels, often the middle cerebral artery or its branches, and prevent the normal flow of blood. The reduced supply of blood and oxygen to a particular part of the brain can result in tissue death, leading to ischemic stroke.
Applications in medicine. Medications are often prescribed to prevent and treat blood clots, which can lead to a stroke. Additional drugs may be prescribed to control heart rate and rhythm in the AFib patient. These medications may also be used in conjunction with other treatments. The heart rhythm can be more difficult to control. The longer you have untreated AFib, the less likely it is that normal rhythm can be reestablished. Medication. Medication options may include blood thinners, rate controllers, and rhythm controllers. Drugs such as blood thinners are given to patients to prevent blood clot formation or to treat an existing blood clot. Examples include Warfarin, other FDA-approved anticoagulants such as Dabigatran, rivaroxaban, edoxaban, and apixaban, direct-acting oral anticoagulants or DOACs, aspirin in rare cases.
And welcome to VideoScript presented by Drugs.com. Today we are reviewing Pradaxa, generically known as Dabigatran. The FDA approved Pradaxa, an anticoagulant, in October of 2010 to reduce the risk of blood clots and stroke in adult patients with atrial fibrillation not due to a heart valve problem. Patients with atrial fibrillation, or AFib, have irregular heartbeats, and are at a greater risk of developing a blood clot that may lead to a stroke. Pradaxa works as a direct thrombin inhibitor and blocks the conversion of fibrinogen into fibrin. This action helps to prevent the formation of a clot. Unlike warfarin, Pradaxa does not require regular blood tests to check the therapeutic effect. However, there are some safety concerns. Pradaxa should not be used in patients who have active bleeding. Kidney function should be evaluated prior to the start of Pradaxa therapy, and in some cases yearly thereafter. Pradaxa should be stopped for certain procedures or surgery, but should be restarted as soon as possible. Because Pradaxa is an anticoagulant, it can also lead to serious or fatal bleeding. Pradaxa should be used cautiously in patients older than 75 years of age, in kidney impairment, and in patients with a history of a stomach ulcer or bleeding. Other common side effects include dyspepsia, also known as heartburn, and other gastritis-like symptoms. In patients with kidney impairment, reduced doses may be needed. There are important drug interactions with Pradaxa. Rifampin should not be used with Pradaxa, as it may lead to a decreased therapeutic effect with Pradaxa. A lower dose or discontinuation of Pradaxa may be needed in patients with kidney impairment who take certain medications, such as Multac or ketoconazole. Use caution when combining Pradaxa with other drugs that increase the risk for bleeding, such as NSAIDs like ibuprofen or naproxen, aspirin, Plavix, or other blood thinners. Other drug interactions are noted in the package labeling, and healthcare providers should check for all potential drug interactions prior to the start of Pradaxa therapy. Pradaxa capsules must be kept dry to prevent the loss of potency. Store Pradaxa in its original bottle and dispose of any unused medication 4 months after opening. Patients who receive more than 1 bottle of Pradaxa should only open 1 bottle at a time. The capsules should be swallowed whole. Patients should not break open, chew, or empty the pellets from the capsules. Patients should not stop taking Pradaxa unless directed to do so by their physician, as this may increase the risk of stroke. Thank you for joining us at drugs.com for a brief review of Pradaxa. Please refer to our patient and professional information, drug interaction checker, and additional tools on drugs.com. Patients with a concern about the use of Pradaxa should consult with their healthcare provider. Visit drugs.com/Pradaxa for more information.
Issue applied in Ecuador. The 4 cardiac diseases that most occur in Ecuador are heart failure, myocardial infarction, atrial fibrillation, and hypertension. In Ecuador, the 4 heart diseases affected approximately 1.4 million people in 2015. The cost of caring for sick people with cardiac pathologies was higher than $600 million in 2015, which represented a loss of 0.6 percentage points of the gross domestic product and 2.5% of the costs of the health sector. Heart failure imposes the highest financial cost with $228 million, followed by myocardial infarction with $227 million, hypertension with $97 million, and finally atrial fibrillation with $69 million.
The topic discussed in EP Live are a sort of a comprehensive approach to different types of arrhythmia and solution for the arrhythmia. So there are cases of atrial fibrillation, ventricular tachycardia, implantable devices, to address with the audience all the technical aspect of this procedure by using the latest technology. The International Center of Cardiac Ventricle has really state-of-art technology, and they've been involved now for a long time in testing also new technology before get to everybody. I feel very comfortable in coming here and doing cases because I know that the type of support and the instrument that I have access to is the same one that I have in the United States. The importance of having a center like this is that that's the only way you can guarantee quality. A center with do lower volume, where there is no systematic approach or access to the newest technology, cannot provide the best care to patients with arrhythmia. This is very important. So without the support that is here in accessing new technology and also the expertise that people build by doing large volume is very important in the outcome of the procedure that we do. So it's very important for the patient and for the people that live around here. What we've seen in the last decade is better ability, first of all, more awareness of rhythm problem, but also better tool to diagnose them. And this is very important because it's the best way to prevent side effect of rhythm problem, so patient can have access to treatment, proper treatment, before they actually find out that they have a rhythm problem because they develop a complication, for example, a stroke from atrial fibrillation, heart failure, or they have a life-threatening event from ventricular arrhythmia. And so having access to a way to document the presence of a problem before patient actually develop side effect or the complication of the rhythm problem is very important.
I'm going to talk about the pros and cons. Pros: offers predictable pharmacokinetics, rapid onset and offset of actions, low potential for drug-drug and drug-dietary interactions, does not require routine laboratory coagulation monitoring, less side effects than warfarin, less risk of major bleeding events. Cons: no specific antidote exists in the event of overdose. Clinical consequences of non-adherence are unknown. Bioavailability can be dangerously increased when the pellets are administered without a capsule shell.
Catheter ablation is an invasive procedure used to treat patients with symptomatic atrial fibrillation, or AF. Complications associated with atrial ablation include periprocedural stroke and transient ischemic attack. Heparin is administered during the procedure, and traditionally warfarin has been used before and after the procedure to reduce the risk of periprocedural events. The role of the newer non-vitamin K oral anticoagulants has been unclear. The ReCircuit trial is a multi-center open-label study that randomized 635 patients undergoing catheter ablation for AF to receive therapeutic doses of warfarin or 150 milligrams of Dabigatran, a non-vitamin K oral anticoagulant, twice a day. All patients received uninterrupted anticoagulation for 4 to 8 weeks before and then during the procedure, and for a further 8 weeks after ablation. The primary endpoint, major bleeding events by the end of the treatment period, occurred in 1.6% of the patients treated with Dabigatran, as compared with 6.9% of those receiving warfarin. The absolute risk difference between the two groups was statistically significant. The composite incidence of major bleeding events and thromboembolic events was lower in the Dabigatran group than in the warfarin group. Serious adverse events such as atrial flutter, congestive heart failure, and cardiac tamponade were reported in 18.6% of the patients treated with Dabigatran, as compared with 22.2% of the patients treated with warfarin. The authors conclude that among patients undergoing catheter ablation for AF, periprocedural anticoagulation with uninterrupted Dabigatran is safe and leads to fewer bleeding complications than uninterrupted warfarin. Full trial results are available at nejm.org.
Conclusion: in patients undergoing ablation for atrial fibrillation, anticoagulation with uninterrupted Dabigatran was associated with fewer bleeding complications than uninterrupted warfarin. Dabigatran was associated with fewer periprocedural pericardial tamponates and groin hematomas than warfarin.
circuit study is a very important study because it's a multi-center, international, randomized controlled trial comparing dabigatran etexolate and dose-adjusted warfarin in patients undergoing an ablation procedure. Previously, doctors have felt that they had to change to a vitamin K antagonist or use bridging techniques or perhaps dropping doses of a NOAC therapy prior to ablation procedures because they're worried about bleeding adverse events. This trial was set up to compare dose-adjusted warfarin and dabigatran absolutely uninterrupted, so no tablets were dropped. Now the results were very interesting. Some 318 patients or thereabouts in both groups were treated, one with warfarin, one with dabigatran etexolate in full doses, 150 milligrams twice daily. They were followed during the procedure and for 8 weeks after the procedure to look specifically as a primary endpoint for major bleeding events defined using ISTH criteria. The results were, to my mind, very interesting because there were 22 bleeding events in the warfarin group and there were only 5 with dabigatran etexolate. Now this was statistically significant. The hazard ratio was 0.22. There was a 5-point-something% absolute risk reduction, which was, I think, completely unexpected that the results would be as good as this. Now this trial has some implications. It will stop cardiologists feeling insecure about using a NOAC drug. It will mean that they don't have to swap to a vitamin K antagonist with all the hazard that encompasses if you do that. It means that dabigatran etexolate can be used very safely, continuously, and therefore patients are not exposed to the risk of stroke by stopping the drug or reducing the dose. It also has, I think, a much broader connotation that relatively low risk procedures can be done safely on a NOAC treatment rather than having to bridge or having to swap to a vitamin K antagonist. So these results are important to the electrophysiology community in particular, but to cardiologists and other physicians across the board.
Thank you for listening.